then to the final aspect of the lecture, and Dr. Kennedy will fill us in on Achilles tendinopathy. Where does PRP work in this application? Dr. Kennedy?
Okay, great. And again, many thanks for listening to this. So we know that, again, chronic Achilles tendinosis is a very common and debilitating injury, and oftentimes conservative treatment is slow with less than optimal results. And one interesting fact is up to 50% of patients or athletes with chronic Achilles tendinosis will end up with some form of surgery. So if you look in terms of the in vivo evidence for PRP and tendon regeneration in terms of the basic science, we can see some great work out of Sweden, has shown that it increases aminoglycans and collagen organization. And the rat patella model shows that a single injection increases the force to failure and increases this tendinous callus that's there. A great article out of Pittsburgh has recently shown that, again, PRP promotes this TSC, or this tendon stem cell upregulation of tenocytes, increasing CD34 and somehow inhibiting SOX9, which would be one of the catabolic products. So again, good in vivo and in vitro evidence to suggest that it may be useful in Achilles. And the reason we're looking at it is because the traditional non-operative treatment of an Achilles tendinosis is onerous. It's 23 hours a day of mobilization in a boot or cast. It's long-term mobilization for up to 3 months. And this is really just addressing the mechanical aspect and doesn't address the biological aspect. Those of us who have operated on these will know that when you open it, it's just this crab meat. It's this amorphous mass. And I think just addressing that in terms of biological aspect, we need to be looking also at we need to look at the biology, not just the mechanics. So when you inject PRP, initially we were just injecting it blindly, and then we used ultrasound. But we've moved on now to tendoscopy, and it's a minimally invasive tendoscopy. It's a relatively quick procedure. It has to be done in the operating room. It can't be done in the office, but it is very, very quick and easy. And it allows you to look to see exactly where the problem is and deliver the biology to that area. So afterwards, we put them for about 7 to 10 days in a cam boot, just again to try and break that inflammatory component to the pathology, and that's followed then by mechanical loading and this functional isometrics for about 6 weeks. So if we look at the results of non-operative PRP treatment in Achilles, it's not terrific. There's a great paper from Holland, from Davos, which shows that roughly equivalent in terms of a control group, around 67 versus 78 with the PRP. If you look at the two other studies, they're relatively similar to our own, where we had about 72% of patients were satisfied, but this was mid-substance. This was not insertional Achilles tendinosis, and these patients did well. But again, in our study, which we haven't shown here, we showed that the MRI results were not that great. They certainly didn't reflect the clinical improvement. But in those patients that go to surgery, we can also use PRP, and it has the theoretical advantage of improving wound healing, reducing infection, early range of motion, and early return to function. And indeed, Sanchez has shown that. He's shown that in his study, and there are really only 2 clinical studies of value in this so far, is that the group that was treated with the PRP at the time of operation returned to their physical sporting activities at 14 weeks versus those who didn't have the PRP at 22. But this study out of Sweden then confounds things a little bit, in that it shows that the PRP-treated group in the peroperative PRP-treated group may have a detrimental effect on the rupture or re-rupture rate, so that's a little concerning. We'll just put in some anecdotal evidence here. It's always useful because this is really what it is. We need truly good quality level 1 randomized controlled trials. But just for some anecdotes, this is a 60-year-old male with bilateral PRP injections who wasn't keen at all on having surgery. We gave him PRP injections with our isometric functional training afterwards, and then he's done well. He's gone back into his triathlon. So that's great. However, I think it should always be mentioned, I think all of us on this panel are proponents of PRP in some form, but again, it should be tempered with the reality of what we use and where we use it. And we need to look at our patients carefully. The 50-year-old NFL offensive lineman coach, he had an insertional tendinosis and was not keen for surgery. We injected him with PRP. He went through the regime, and he had no improvement whatsoever. So he's not a believer in PRP, and that may be because it was the wrong indication in the wrong patient. So just to summarize, PRP may avoid surgical intervention amid substance tendinosis, and it may improve surgical outcomes in postoperative rehab. And to look at this more clinically, we've involved Pittsburgh and Oslo in terms of doing a randomized controlled trial in multi-center, because I think that's really the only way we're going to know whether PRP really gives a good effect in Achilles tendinosis.
Great, thank you very, very much. One of the questions came up for your injury after tendinopathy about is there any time limit in terms of the disease process moving on that you would not use PRP? In other words, is there a way to tell if the disease process has progressed so far that you don't believe PRP and Achilles tendinopathy would be efficacious?
There may well be, but there's no real evidence to suggest that we've reached a timeline. I mean, I think if you think of the effects of PRP, it probably is temporal. In other words, there's a sequence of events that we're affecting, and the earlier we get in there, the more likely I believe that we'll have a good outcome. But again, I bring it down to this thing. It's not just the biology. You've got to, in my mind, you've got to think this is an amorphous diseased tendon at the more chronic stages. And so we do this peppering with a needle, trying to produce these neovascular channels in there, because I think it's very important. We may have, again, it sort of goes back to the BMP debate of 10 years ago. You can put all the BMP you want into a spine, but unless you produce angiogenesis, it's never going to work. And I think the same thing applies, not necessarily in cartilage, but certainly within tendon injuries, that we've got to provide an angiogenic pathway or highway for these factors to work. And so that's why we do this sort of brisement and multiple, almost like the Mafuli technique, where we're creating small little areas that we deposit our PRP, again, to try and improve that angiogenic or neovascularization.
How many injections would you use and then when you would come to the conclusion that perhaps it's not going to work? Would you do 1, 3, 4?
And again, you know, this is based on Gestalt rather than on true science. We give one injection, and if the patient has no clinical or ultrasound evidence of improvement at 3 months, it's very hard for me to tell them we're going to do the same thing again. If it's failed once, the likelihood is, in my belief, that it may not work again. But if they get some response, then we can certainly talk about giving a second injection. But this is what we need. We need to look at whether one injection is good. It's like the old thing, 2 teaspoons might be good, 3 teaspoons may not be any better in your cup of tea. It's the same thing with PRP. What's going to make the difference? And I think that if you, and that really is what we're going to be looking at in this randomized controlled trial. Do we give it into the tendon or do we give it around the tendon? Again, do we give an injection of lidocaine around there, or is that detrimental to PRP? Many of these questions, there's no good answer because there isn't enough science yet there to support it or not.
Well, speaking of that, we did have a question on local anesthesia. So even if we don't have the science, I guess we would rely on people's expertise. So we'll start off with Dr. Kennedy. Do you, in the office, do you use a local anesthetic when you give your injections?
I do, and I know there is some evidence to suggest that local anesthetic may cause damage to the PRP, but again, that's in the laboratory. And the reality is that, again, my patients aren't keen at me charging at them with a needle unless I give them some form of local anesthetic. So I think we have to be sensible about it. I think if you give a bleb of anesthetic into the skin, it'll certainly help them and it'll relieve their tension. And you can then use your needle to inject into the tendon without too much discomfort to the patient. So I do use local anesthetic, yeah.
Alan?
I do the exact same thing. I put a little into the skin, and I use 1% plain lidocaine for the Achilles, and would